Hey, Happy New Year. I am so glad to be here this year. There's a lot of people that didn't make it to see 2021. So I want to thank you so much for tuning in today. This is our Sugar Busters education series. I'm Dr. Lenore Coleman, president and founder of Healing Our Village and the executive director of my nonprofit, Total Lifestyle Change. And I want to welcome you today tuning in. We advertise this throughout the week. We're working with doctors' offices, hospitals, healthcare plans across the country. And for those of you that want to participate and get more of our educational programming, let your doctors know that we're here every Saturday bringing this information to you and your family, your friends, and our community. Sugar Buster series is really a series that focuses on diabetes, its complications, how to manage diabetes, what to eat, what not to eat. So we do a 6-part series. So we'll be coming to you every Saturday over the next 6 weeks, where we actually talk about all these various aspects of diabetes. And then we repeat the series for those of you who maybe missed the first couple of segments. If you ever have questions about your diabetes, we're here for you. Healing Our Village, 800-788-0941. We are here to answer your questions about diabetes. Listen, folks, right now, I don't know if you know, but there's a global pandemic, okay? COVID-19 is here. What's really struck me over the last couple of months is that if you haven't been personally affected, if you don't know someone who actually got COVID-19, or you haven't lost someone, so the 400,000 people, so let me say that again, 400,000 people who have lost their life to this virus, then, a lot of you just don't really think it's real. It hasn't impacted you personally, but I'm here to tell you that this virus is real, that this virus is serious. And why we here at Healing Our Village is so focused on this is because we know that people with diabetes actually are at a 50% higher risk of the severe complications of COVID. And many of that 400,000 people who have died because they had diabetes, or they had hypertension, or they had COPD, or they had obesity. And so we can actually fix some of that. We can actually get your diabetes into good control. We can actually get your numbers where they need to be. So if on the off chance you get COVID-19, your chances of survival, it's going to be higher. So there is no excuse at this stage of the game for you to have hemoglobin A1Cs, which is the measure of how well your diabetes is doing. There is no excuse for you to have a hemoglobin A1C that's greater than 8%. And we really want to get you all down to 7%. So if you don't know your numbers, you need to know your number. You need to know your blood pressure number, your hemoglobin A1C number, your cholesterol number. Knowing your numbers is critical. And so it's very important that if you don't know them, you need to know them, because you can't really manage your diabetes if you don't know your numbers. So this is our diabetes series. Again, Sugar Busters, this is part 2. We did part 1 last week. So last week we did diabetes overview and the importance of monitoring your blood sugar at home. If you don't have a blood glucose monitor, go to our website, hovhealth.com. We have low-cost meters and strips right there on our website. Today, we're going to talk about medications. Now, I've been taking care of people with diabetes for 40 plus years. I am an old lady. Okay, I don't look old, but trust me, I'm an old lady. And I have seen so much research and such amazing medications that 40 years ago, they weren't available for me to use to help to treat diabetes. So we're going to talk about all of these various classes of medications. And the one thing I want to tell you is that at Healing Our Village, we're not doing one size fits all. When we talked about diabetes overview last week, what I tried to emphasize is that everybody's diabetes, the physiology of their diabetes is different. And so the right medications are based upon your physiology. I can't just use just every medicine, the same medicine for every person that I'm taking care of. And so it's critical that you work with organizations, work with doctors, work with diabetes educators that understand that, so that we're going to pick out the right combination of medications for you specifically. And the only way that we can do that is for you and I to work together, for us to adjust your medications, figure out the right medication for you, and then help you then combine your medications to your lifestyle, to your exercise routine, to the foods that you eat. So all of this stuff works hand in hand. It all works hand in hand. So today we're going to talk about the medications that are out there available on the marketplace. But this is the interesting thing. A lot of you, because of the kind of healthcare plan that you have, you might not be able to get some of the medications I'm talking about today. They may not be on your health plan formulary. Or if they are on your health plan formulary, they may be at what we call tier 3. So in order for you to even get the medications, your doctor has to write us something special called a prior authorization. They have to send documentation to your health plan for you to even get some of these medications that I'm going to talk about today. So I think it's critical that in 2021, that we need to have people on the right medications for their diabetes. And we need to relook at the way in which patients with diabetes in this country have access to some of the newer medications that are out there. I think that's really, really critical. Okay, so let's get started. So when you talk about the types of diabetes medications that are out there, we have oral medications, we have injectable medications that are non-insulin, and then we have insulin, which is also an injectable medications. Now, who should be on oral medications? We have to first realize that oral medications that are out there on the market are not oral insulin. A lot of people think that the pills that they're taking are actually insulin in a pill form. That's not true. The oral medications, the way that they work is they either make your body make more insulin. Okay, so they work at the area of the pancreas or the gut or various areas of the body to make your body make more insulin. And then some of them actually help your body use your own insulin that's inside your body right now work better. So even though the medications are available, I don't want you all to forget that the first line of treatment for the management of diabetes is healthy eating, nutrition, watching they call diet, right? And we don't like to use that word anymore. And also exercise, and getting exercise on a daily basis, which I'm telling you, it's hard. Right now, there's some of you out there that are shoveling off your driveways. It's snowing someplace. It's bright and sunny here in Georgia. Okay, praise Jesus for that. But there are places in this country that there's snow on the ground. And so it's sometimes hard for you to figure out how you're going to get your exercise in when you're in the winter months, because you can't do what maybe you usually do, which is go to the park and walk around the park or jog or ride your bike outside. So you got to get creative in the wintertime to be able to figure out how to get your exercise in. So again, diet and exercise are the first line of treatment for the management of type 2 diabetes. Now, let's talk about how the different diabetes medications work. Some of them actually increase insulin production and release from the pancreas. Some of the medications actually slow down the breakdown of the carbohydrates, the sugars and the starches that you're eating, and help those carbohydrates get absorbed better. Some of the medications increase the ability to move that glucose that's in your blood inside of the cell. And then some of the medications actually decrease the production of glucose from the liver. Your liver, especially at night, actually produces glucose throughout the night because you're not eating. And so the body has to have sort of a stable output of glucose so that the brain and the various parts of the body continue to function. So what the liver does is it actually produces glucose during the evening hours. So for those of you who have that as part of your physiology, then we're going to use a medication that decreases that production of glucose from the liver so that when you wake up in the morning, you don't have high blood sugars. Now, this is a very busy slide, but I want you to see this slide. And there's two things I want you to pull from this slide. The first thing is that we now know that it's called the egregious 11. We now know that there are 11 different physiologic pathways in the body that can make your blood sugar go up, can cause hyperglycemia, which is in the middle. And so the reason why this is so busy is when I graduated from pharmacy school back in 1979, I'm doing this a long time, as I told you, we only had a couple of medications. We only really knew about a couple of pathways that actually increased your blood sugar. But now, because of the science and the clinical trials and all of the research that's being done in the area of diabetes, we now have learned so much about what causes your blood sugar to go up. So we always knew about the pancreas, right? That was sort of the core defect. We knew that in people with type 1 and type 2 diabetes, there was a decrease sometimes in insulin secretion. So we knew about that, right? And then I talked to you about the fact that there was something going on with your liver. We knew about that early on as well. But these are things that are now called the decreased incretin effect, which is incretins are these things that are actually secreted in your gut, right, in your intestines. We didn't really know much about those, but we now know that they are huge in terms of your ability to keep your blood sugar down. We also know that your peripheral muscle uptake, it can be increase your blood sugar. We know that there's your fat, the amount of adipose tissue that you have in your body can increase your blood sugar. We also know that the colon is involved. The kidney is involved. The kidney is one of the newest areas where we found that there are things within the kidney that can be affected by drug therapy and decrease the reabsorption of sugar back into the body. So we're going to go through all of these various classes of medications today so that you can think about which one you're on so that you can then link them up in terms of your specific physiology. So take a minute, maybe go get your medications, have them sitting in front of you. So as I start going through the names of these various medications, you'll be able to know which ones you're on and which ones are affecting your blood sugar and the mechanism that they're working inside of your body. So let's start off with the non-insulin agents. These are some of them are injectable, some of them are oral. All right. We're going to kind of go in alphabetical order. So there are the alpha glucosidase inhibitors. They delay carbohydrate absorption. The biguanides, they're the ones that's metformin, and they are the ones that affect the liver. There's the bile acid sequestrants, the DPP-4 inhibitors. They're relatively new on the marketplace, and they basically decrease glucagon secretion and increase glucose-dependent insulin secretion. So they affect that insulin secretion from the pancreas. You got your dopamine 2 agonists. You got your glinides. Very few people are on those medications, but they increase insulin secretion as well. And the newest class of medications that I'm excited about are the GLP-1 agonists. They increase glucose-dependent insulin secretion, but they also affect your appetite. That's a big deal because we know that people that have type 2 diabetes specifically tend to be obese, and they tend to eat more calories than their body can handle. And so just think about taking a medication where you kind of aren't hungry, where you actually forget to eat. I have been struggling with my weight my whole life. I've lost 10,000 pounds. You know, that same 5 pounds that I have lost over and over and over again. All right. So these medications to me really make a lot of sense because of their multiple different mechanisms of action. We also have the SGLT2 inhibitors. They're also new to the marketplace. They increase urinary excretion of glucose. So they help your kidney push out that glucose. The sulfonylureas have been around a long time. They increase insulin secretion. Many patients in the country are on those drugs. I tend to not like them as much as I like the newer agents, mainly because they tend to cause low blood sugar reactions, and that's not good. And then the thiazolidinediones, they also are have been around for a while. There's still some of you that are on those medications, and they work pretty well, especially if you use them at lower doses. When you start getting some of the higher doses, then they can sometimes cause an issue. Now, those are the orals, all right, and injectables for type 2 diabetes. Now, there are also insulins. Now, insulin is used by type 1 diabetes and for patients that have type 2 diabetes. Insulins are either basal insulins, which is basal insulin is secreted throughout the day by your pancreas. And there are insulins that look like basal insulin in that they have a very long duration of action in your body. So there's basal insulins, there's prandial, which means before a meal, prandial insulins. And then there are insulins that have both short acting and intermediate or long acting insulin in the same bottle. So these are called pre-mixed insulins. Now we're going to go through each one of these medications separately. So let's start with the biguanides. That's metformin. A lot of you are on metformin. Metformin tends to be the first line medication that most doctors in this country start with, unless you have kidney dysfunction, unless your kidneys aren't working that well. Most patients start with metformin. Metformin keeps that liver from releasing too much glucose, from producing glucose at night specifically. And there are some combination pills out there that have metformin in it. So it's metformin plus glyburide or glipizide or rosiglitazone, and there are some of the newer agents that are combined with metformin. I actually like combination pills because that way it makes it easier for you to remember to take all your medicines, and there's less of what I call a pill burden. You don't have to think about taking so many pills every day. Unfortunately, most formularies, most healthcare plans do not cover combination products. And I think we need to relook at that. We need to think about that, because what the most important thing that when we're talking about medications is that you take it every day. And whatever we can do to help you take it every day, we should be trying to do. The next class is your alpha glucosidase inhibitors. That's your Preclose and your Glycet. Acarbose is the generic name, and Miglatol is the generic name. These drugs have been out for a while. They work in the area of the small intestine. And what they do is when you eat your sugars or you eat your starches, they slow down the absorption of those carbohydrates in your small intestine so that you don't have these spikes in your blood sugar. So you don't want to have your blood sugar go up and to high levels and then come down. We want to keep your blood sugar steady if we can over the day. And the reason why we don't want the spikes in your blood sugar is that's when the damage happens. That's when the damage happens to your nerves, to your eyes, to your kidneys, to your blood vessels. So these slowing down then therefore the digestion of the carbohydrates decreases those spikes. A lot of patients have don't necessarily like this class of medications, mainly because of the diarrhea and the nausea. But the good news is if you've taken it for a month or so, about 6 to 8 weeks, those side effects tend to lessen and go away. And if you modify what you eat in your diet, those medications also cause less of the nausea and the diarrhea. The DPP-4 inhibitors are another relatively newer class of medications, all right? You can tell that you're on one of these because the end of the word is leptin, okay? So Januvia, Onglyza, Tradjenta is your sitagliptin, your saxagliptin, your linagliptin. So again, you're looking for the word gliptin. The way that they work is they decrease glucose output from the liver, and they also increase insulin release from the pancreas. In terms of side effects, you got your nausea, you got your diarrhea, you got maybe some stomach pain. with these DPP-4 inhibitors. They especially work well in patients who are newly diagnosed. So that means that their A1C levels aren't very, very high. So they just started having diabetes and they're newly diagnosed. These agents work very well, and they tend to be used in combination with other medications. So they usually get added on, let's say, to your metformin. The SGLT2 inhibitors, again, these are newer agents that are on the market. The exciting thing about the SGLT2 inhibitors is they've been some huge clinical studies which recently have been reported out and have shown that these drugs actually not only help manage your diabetes, but they are beneficial for patients that have either kidney disease or heart failure. So these are drugs that now doctors are looking at in patients that have both diabetes and heart disease or diabetes and kidney disease. These drugs now are being added on to, say, your metformin as a combination so that you can get some risk reduction as it relates to heart attack, strokes, heart failure, or kidney disease. The way that these drugs work, again, is causing the sugar that's in your body to be urinated out through the kidneys into your urine. So as the blood passes through the kidneys, the kidneys filter out the blood sugar and some water. They return that back into the body, and then the excess water and the glucose are eliminated from the body. Side effects are potentially dehydration, right? And then some patients, especially women patients, have vaginal yeast infections that we see with this particular class of medications. So these are, again, new. The fact that they can decrease some of your long-term complications, the risk of those complications, I think, is important. There are also combination products. I mentioned that earlier. Here are a list of some of the combination products that are out there. It's important to, if you're having a hard time managing the number of medications that you have to take every day, having a conversation with your doctor about maybe combining some of the medications you're taking and just using a combination pill. And again, as I said, that doctor can write an authorization to your healthcare plan to get their permission to prescribe the combination products for your diabetes. You know, if you don't take your medications, they can't work. You got to take them. Medication adherence is what I spend my life doing. I'm a pharmacist by training, certified diabetes educator. I spent the last 40 years trying to convince patients to take their medications as prescribed. So there are some tips that I want to give you in terms of taking your medications. Try to take them at the same time every day so you can get into a routine. Some people associate their medication taken to a daily activity. So let's say you get up in the morning, you're having your smoothie, right? Well, have your pill bottles right there by the blender. So as you're taking your smoothie, you're taking your morning medications. You can give yourself clues to help kind of remember to take your medications. And if you're having trouble, I really suggest you get one of the medication pill boxes, as you see in the picture here, and that really can help you be able to remember to take your medications. Some medications actually cause an upset stomach, so for those medications, you need to take them with meals when appropriate. And so you have to ask your pharmacist when you go to pick up your medication, should any of my pills be taken on an empty stomach, or should I take them with food? That's a question that you need to ask your pharmacist when you go to take your medications. Store your medications at room temperature. That's important. Do not take expired medications. So look on your pill bottles. I have patients call me all the time and say, you know, my medication expired 2 months ago. Can I still take it? And my answer generally is no. You shouldn't take expired medications. And look at your medications. If they have spots on them or they don't look quite right, if they're discolored, then you need to go get a new prescription. And always remember to take your medications with you when you're traveling. Do not pack them in your suitcase. Put them in your carry-on luggage or in your a place where you can have them available just in case your luggage doesn't show up. Okay, because once you go to a different place, it's going to be hard for you to get those medications. Let's talk a little bit about injectable medications. Well, here's that class that we've talked a little bit about, the GLP-1 analogs. These are the newer medications that I mentioned. You have the various names there: Ozempic, Victoza, Byetta, uh, Tanzium, Trulicity. You've seen a lot of commercials, I'm sure, on the TV. All of those belong to this class of GLP-1 analogs. Now, the cool thing about these drugs is they already come in a pen. So these are injectable medications, but they come in a pen, so it'll make it easier for you to inject. Some of them need to be injected every day. Some of them need to be injected once a week. So a lot of you are now starting to be prescribed the once a week medications. And brand new, the semaglutide, okay, which is your Ozempic, which is an injectable medication, and your Rybelsus, which is an oral medication. This is the first oral GLP-1 agonist. Now, the way these drugs work is they increase insulin release from the pancreas, but they also increase your cell's ability to use the insulin most effectively. They also make you feel full. They decrease your hunger. These are the ones that really help with satiety, is what they say. That's decreasing how hungry you are. There are some people who take these medications and they actually forget to eat. And that's uncommon in people that have diabetes, okay? Forgetting a meal is not something that they do. Okay, they're usually eating breakfast, figuring out what they're going to eat for lunch. All right, so this is something that we see commonly with people with diabetes. And so the fact that these drugs make you sort of decrease your hunger is important. All right, they come, as I said, in a pre-filled pen. You need to store the medication that you're not using in the refrigerator, but the one that you're using can be at room temperature. Side effects are dizziness, headache, loss of appetite, which for some folks is good, and weight loss, all right, which is, they say, as a side effect, but it might be a benefit to some of you who are trying to get off that extra 10, 15 pounds. Some people lose weight with them, some people don't, or some people lose a little bit, some people lose a lot. So again, the thing about diabetes is one size does not fit all, and medications affect different people different ways. Now, let's talk a little bit about insulin. Who are the candidates for taking insulin? Well, insulin is used both in type 1 diabetes and type 2 diabetes. People with type 1 diabetes, as we talked about last week, have to take insulin. They have no other choice because their pancreas no longer has insulin to secrete to help control their blood sugar. People with type 2 diabetes, some are on insulin, but it's not because they don't necessarily have any circulating insulin in their body. People with type 2 diabetes, some of them have plenty of insulin. In fact, they have too much insulin. It's just that insulin doesn't work correctly to get the blood glucose out of the blood into the cell. Some people may need to use injectable insulin just temporarily, like your women who have gestational diabetes. They have diabetes during pregnancy. Or if you have a severe illness or you come in for a surgery, you may need to have insulin started in the hospital. A lot of the COVID-19 patients that have diabetes, when they come into the ICU with their COVID infection, it's an infection that during that time that they're in the hospital, they will discontinue their oral medications and start them on an insulin drip in order to be able to control their blood sugar. So insulin can be used either long-term or it can be used temporarily. So when you're talking about the timing of insulin in your body, what normally happens is that the pancreas secretes a steady amount of insulin throughout the day. That's called your basal insulin secretion. And then when you're about to eat a meal, for every meal, based upon how much carbohydrate you have, how much sugar and starch is in that meal, the pancreas is going to send out a boost of insulin. It's going to send out an extra amount so it can take care of that food that you've just eaten, especially the carbohydrates and the starches. So the basal insulin, again, is released all day long. It keeps the body from breaking down fat cells. So that's what basal insulin that's normally in your body, but if you're taking basal insulin, that's what it keeps your body from doing. It keeps your body from breaking down fat cells. So interesting. All you all out there on a keto diet, all right, well, you're trying to break down your fat cells by the kinds of foods that you're eating. So, therefore, you're actually monitoring your ketones that appear in your urine. So, some of you are testing your ketones in your urine. Well, ketones come from the breakdown of fat cells. All right, so that insulin that's being secreted all day, the basal insulin, keeps your body from breaking down your fat cells. All right, because that ketones we don't want ketones in necessarily, because if your physiology gets out of whack because of what you're doing, some people with ketones in your urine actually is a sign that you need to that your body is going into a dangerous state where ketones can be cause acidosis. So this whole idea of keto diets and breaking down ketones is something that you really need to talk to your doctor about or your dietitian about. Also, that basal insulin keeps your liver from producing sugar at night. Now, those of you who are on insulin, all of your type 1s, they're using basal insulin and bolus insulin. They're taking insulin to cover their meals. And the amount of insulin that you take is based upon how much you're eating during that meal. All right, so mealtime coverage is important if you're using insulin. And so it's very important that as you're looking at controlling your blood sugar, what my diabetes educators do is they time your insulin to your food intake. And that is very important. You don't want to have insulin on board if you don't have food on board, because that's how you get low blood sugar reactions. All right, so we're going to continue talking about medications, but let's take a break. Get up, walk in place for about a few minutes. Go get your medications again so they're right in front of you. If you have any questions, please call our 800 number, 800-788-0941. We'll be answering questions throughout the week. So just leave a message and we'll get right back to you on any questions that you may have. So let's take a break. Hi, this is Dr. Lenore Coleman, President and founder of Healing Our Village and Executive Director of Total Lifestyle Change. Welcome to Diabetes, the Truth About It. Is your blood sugar under good control? Do you understand the effects of diabetes on your eyes and kidneys? Are you on the correct insulin injection? Are you having trouble controlling your weight? Are you following your physician's advice? It is critical that you're using your diabetes medicines correctly. Diabetes, the Truth About It, is here to help you. Check out HOV Health to learn everything you need to know to manage your diabetes and prevent complications. Do you think you have diabetes? Normal blood sugar is 60 to 100 milligrams per deciliter. You have prediabetes if you're between 101 and 126. And we diagnose you with type 2 diabetes if your blood sugar is 126 milligrams per deciliter or greater. The symptoms of diabetes can be different for every person. Are you always thirsty and hungry? Do you urinate many times during the day, especially at night? Have you been experiencing blurred vision or not seeing things as clearly as normal? Have you been experiencing tingling or numbness in your hands and feet? Have you noticed sores in your legs and your feet that don't seem to want to heal? Are you getting vaginal or urinary tract infections more frequently? Do you have to see your dentist more often because you have more cavities? All of these may be the signs of diabetes. If you're experiencing any of these symptoms, make an appointment to see your doctor right away. Thank you for watching Diabetes, the Truth About It. For more information on how to control your blood sugar, sign up for Village Club today and get your own personal diabetes coach. Go to www.hovhealth.com or call 800-788-0941. Remember, you too deserve to live a long and healthy life. Hi, this is Dr. Lenore Coleman. Thank you so much for tuning in today to Diabetes, the Truth About It. Remember, if you have any questions or any comments, give us a call at 800-788-0941 and visit our website again at hovhealth.com. All right, welcome back. Welcome back. Today we're doing sugar busters, medications, and we were talking about insulin therapy. And again, we got insulins that are out there available that you can use to inject into your body to control your blood sugar. So there are basically three types of insulin. There's your bolus or rapid acting insulin. Those are the ones that you inject prior to a meal to control, again, your sugar and starches that you've taken in on during that meal. You got your basal insulins. We have both NPH and Lente and Lantus and Levemir. Those are long-acting insulins. Basaglar is another long-acting insulin. And then there are combinations where there is the short-acting insulin and the intermediate or long-acting insulin inside the syringe. So those combinations are either 70-30, which means it's got 70% of the is the NPH or intermediate-acting insulin, and 30 is the fast-acting insulin. Combination insulins are good. I like those. But we don't want to start them until I figure out exactly what your insulin needs are based upon your diet and exercise routine. And then once I figure out exactly how many units of the long-acting and the short-acting insulin you need, I can then see if there's a combination that makes sense for you to use. So I think combinations are something that can help patients because you don't have to inject multiple shots. In terms of when should you inject insulin, what's your timing? Your rapid-acting insulin should be taken within 15 minutes of a meal. In fact, some of the rapid-acting insulins can be taken right before the meal because they actually start working within 5 minutes. They usually have their maximum effect, or they peak at 1.5 to 2 hours, and then they're pretty much out of your body after about 4 to 5 hours. So these are the insulin, the short-acting, rapid-acting insulins. They're the ones that be taken with meals. And if you're not going to eat, if you know that you're running late, you had to get to the office early, so you couldn't eat breakfast, whatever it is, you're working too hard to go to lunch, you didn't bring your lunch with you. If you're not going to eat, you don't take these insulins because these insulins are going to bring down your blood sugar whether they're high or not. So that's how you get into trouble. That is how you get these low blood sugar reactions. Now, the short-acting insulins take 30 minutes before the meal, all right? Whereas we said the rapid-acting insulins can be taken 5 minutes before the meal. And again, if you're not going to eat, you shouldn't take it. Your long-acting insulin should be taken usually once a day for most people. About 80% of people can get away with 1 shot a day of a long-acting insulin, usually taken at night. And why we usually take them at night is because we want to cover that hepatic glucose production, that production of glucose from the liver. And so if you take it in the evening hours, then that insulin will be at its highest level during the night when that liver is producing sugar. So therefore, when you wake up in the morning, your blood sugars won't be high. All right. So timing of those insulins, I think, are really important. Now, I had a patient a few weeks ago who didn't seem to produce any sugar during the night. And so she was having severe low blood sugar reactions because of the timing of her insulin. So we stopped giving her insulin in the evening hours, and we started giving her long-acting insulin first thing in the morning. And all of a sudden, she stopped having low blood sugar reactions. So again, timing of the insulin really is based upon your physiology. And again, it's not one size fits all. Now, there are some of the long-acting insulins that should not be mixed in the same syringe as your short-acting insulins. So you need to ask your pharmacist about that when you're using 2 types of insulin. So if you're on Lantus, for instance, it has to be given separately from your short-acting insulins. Okay? In terms of insulin pens, I think everybody with diabetes in this country need to be using insulin pens. I think in 2021, no one should be drawing insulin up from a bottle. So that needs to be covered on every healthcare plan because it increases adherence. Okay, you're more likely to inject it if you're using a pen. Your whole attitude about injecting insulin will change if you're using the insulin pens because the needles for the insulin pens are microfine. You can't even hardly feel them. And more importantly, when you're drawing up insulin into an insulin syringe, sometimes the lines are so small you can't really see what the dosage is supposed to be. So a lot of folks out there are not dosing their insulin accurately. If you have a pen, you just dial in the number of units that you need. So it increases the accuracy of the dosing tremendously. And it helps you in terms of not necessarily having to mix insulin because some of the insulin combinations come in an insulin pen. So you don't have to worry about drawing up so much of one insulin and so much of another. So insulin pens, I think, are critically important. Where should you keep your insulin? Well, the unopened bottles can be kept in a refrigerator, but the ones that you are using need to be stored at room temperature. You never, ever want to inject cold insulin. So let's say you forget and you haven't pulled it out of the refrigerator, then go ahead, pull it out, wait a little while, usually about 15, 20 minutes. Try to warm it up between your hands if you can, so you're not injecting cold insulin. The reason why is because if you do that, it causes lumps to creep underneath you and dents underneath your skin. You never freeze insulin, and you should always have an extra bottle of whatever you're using on hand. You never want to run out of your insulin. Where do you inject insulin? Well, you can inject it in your abdomen, which is what most people do, or your upper or outer arm, or you can inject it in your buttocks. You can usually inject it in a layer that has some subcutaneous tissue there, so you kind of pull up the area that you're going to inject in. And you need to rotate your injection sites about an inch apart for each injection. So if you're injecting your abdomen, you're sort of going in a circle. You're rotating an inch apart where you're injecting that insulin. And you never inject in the belly button or into scar tissue. It's important that you dispose of your needles safely. You can get one of these Sharps boxes right there at your pharmacy. Or if you want to just use a laundry detergent bottle or a milk carton, just make sure that it's secure. It has a lid, and right on it, needles do not recycle. All right, so that and then throw it into your trash. So disposing of your needles safely, or your insulin lancets for your blood glucose monitors, all of those need to be disposed of safely. So why do so many people have such a hard time with their insulin? Well, a lot of fear and anxiety from injecting insulin. But that comes from years ago when the insulin wasn't as pure as it is now. It caused more problems in terms of side effects, low blood sugar reactions. The needles were not nearly as microfine. There was no such thing as an insulin pen. A lot of people think that if they started on oral pills and now they have to be moved to insulin, that it's because they're getting sicker and sicker. And so they feel like that makes them have to admit that their diabetes is getting worse if they accept the fact that they need to be on insulin therapy. So they're in denial. This is the deal. If you live long enough, there's a good chance if you have diabetes that you will need to be on insulin therapy at some point, especially if you're not going to watch your carbohydrate intake, your starches and your sugars, especially if you're not going to really get into a exercise routine that you can do on a regular basis and lose that extra 10, 20 pounds that you may be carrying. So if in fact you're not going to do those things, then there's a good chance you may need to be on insulin in order to get to those goal numbers that we talked about. Less than 8% hemoglobin A1C, trying to get for some people, we want you to be at 7% or less. For your people who are older, who have maybe some heart disease, we want you to be at 7.5% hemoglobin A1C. So in order to get down to those numbers and stay there, you may need to be on insulin therapy. Because at the end of the day, what we're trying to do is prevent the long-term complications of diabetes. And they're severe. Heart attacks, strokes, kidney disease, eye disease, nerve disease. We want to stop those from occurring. And the only way to stop the complications, both long-term and short-term complications, is to get your blood sugar under good control. Some people have a hard time getting on insulin because there's physical barriers to being able to do the insulin injections. They have tremors in their hands, or they say they're a truck driver and they just don't know how they're going to figure out how to do their insulin while they're on the road. And then again, as I said, this misconception that my diabetes must be really, really bad if I have to take insulin. And that's not true. All right. Doesn't mean your diabetes is really, really bad. It just means that we're going to need a little extra help to get you under good control. There are some other medications that you may be using out there. If you have diabetes, a lot of folks with diabetes are on aspirin therapy because you're predisposed to heart attacks and strokes. Especially if you've had a heart attack or stroke, we'll have you on a low dose aspirin to help keep your blood thin so you won't throw any clots. A lot of people with diabetes have high cholesterol levels, so we're going to have you on statin drugs to control your cholesterol. We want to have your cholesterol below 100, 70 to 100 milligrams per deciliter. That's your bad cholesterol. And so we'll have you on a statin drug to make sure that your cholesterol is being maintained at a healthy level. And then a lot of folks out there have high blood pressure along with their diabetes, and they may be on an ACE inhibitor. ACE inhibitors and ARBs, angiotensin receptor blockers, and the ACE inhibitors both are used for high blood pressure, especially in people with diabetes. And the reason we do that is they have been found to protect your kidney. Because one of the long-term complications of diabetes is kidney disease. So we use these agents to lower your blood pressure and also protect your kidney at the same time. So that is our medication segment of Sugar Busters. I want to thank you all so much for tuning in today. As I said, this is a 6-part series, and then we repeat the series. So if you miss something, that's okay. Come on back and you'll be able to enjoy listening to everything you need to know about the management of diabetes. We encourage you to go to our website, hovhealth.com. There's lots of really good videos on there on demand, free of charge. Again, we said our blood glucose meters and our blood pressure cuffs are there in our store, our Village store. And we have something called Village Club. Everything's about the Village, folks. Everything's about the Village. And so we have something called Village Club where you, for $5 a month, will be able to get hooked into all of our diabetes educators to be able to talk to you about getting your blood sugar under good control. And we especially encourage those who have either not had COVID and have diabetes, but those even that have had COVID and still have diabetes, you need to tune in and be able to talk to someone to get your blood sugars and your blood pressures under good control. So thanks again. For those who want to learn a little bit more today about COVID, we're going to do another session here at about 12:30. So come on back. We'll be streaming to you live again. Frequently asked questions about COVID-19.